Hello everyone, welcome back to Noteworthy ENT. We are going to talk about Meniere's disease today. So, Meniere's disease is an idiopathic inner ear disease which was first described by Prosper Meniere in the year 1861, and this is characterized by recurrent attacks of spontaneous vertigo accompanied by fluctuating or progressive sensorineural hearing loss along with tinnitus and aural fullness in the affected ear. We'll discuss these symptoms one by one in further detail. Firstly, about the epidemiology part. So, the most common age group affected is second to sixth decade of life, with there being no gender predilection. And the majority of cases are sporadic in nature, with only 5 to 15% of the cases having a familial predisposition. Now, the pathophysiology. Now, it is considered to be an idiopathic disease. That is, the exact etiology is not known at present. However, Holpike and Keynes they have suggested that it has a relationship with endolymphatic hydrops. This endolymphatic hydrops means that there is increased pressure in the endolymphatic chamber. Now we'll discuss this a little bit more with this diagram. So this is a cross section of the cochlea, with this being scala media or the cochlear duct, scala vestibuli and scala tympani, this being the Reissner's membrane and the basilar membrane. And this scala media is filled with endolymph and these two with perilymph. So endolymphatic hydrops mean that there is increased pressure in the endolymphatic chamber, and this causes bulging of this Reissner's membrane. And traditionally it is believed that there is periodic rupture of this Reissner's membrane which causes mixing of perilymph and endolymph, and this leads to attack of vertigo or the episodes of vertigo. However, this has been challenged in recent literature and this may not be actually true. Now coming to the predisposing or the precipitating factors, they may be genetic variations, infections, vascular risk factors, a high salt or an increased caffeine diet, allergies, and endocrine and autoimmune factors. Now, coming to the clinical presentation, the classical features are recurring attacks of spontaneous vertigo, fluctuating hearing loss, tinnitus, which is classically low pitched and roaring type, along with aural fullness. Now, coming to the vertigo part, the patient describes it as spontaneous rotational vertigo, which lasts for at least 20 minutes and it may last up to 24 hours as well. And this spell is usually accompanied by nausea and vomiting. Other GI disturbances like impending doom or sweating may also be there. However, consciousness is not lost in this episode. Now, hearing loss. It is a fluctuating hearing loss in the initial stages, which may later become permanent in the later course of the disease. And initially, the lower frequencies are affected. Now, let us see this audiogram. We can see the right ear audiogram is normal, whereas on the left side, there is low frequency sensorineural hearing loss. Now, I have discussed all these audiograms more in detail on the lecture I have made on how to interpret a PTA. The clinical examination part. Now, we can elicit spontaneous nystagmus in the acute setting. Now, nystagmus is involuntary, rhythmic, oscillatory to and fro movement of the eyeball, and it has a fast component and a slow component. And we denote the direction of nystagmus by the fast component. For example, if the fast component is towards the right side, it is denoted as a right beating nystagmus. and vice versa. So in the irritative phase, the nystagmus will beat towards the affected ear, and this may last up to an hour or so. Then comes the paretic phase where it beats away from the affected ear, lasting for hours to days. And then comes the recovery phase when again the nystagmus beats towards the affected ear with the duration similar to that of paretic phase of hours to days. Then we'll move to the diagnostic criteria. It was laid out by American Academy of Otolaryngology and Head and Neck Surgery. Now, there are two classes, that is definitive Meniere's disease and probable Meniere's disease. Now for the disease to be definitive, there has to be at least 2 episodes of spontaneous vertigo lasting for 20 minutes to 12 hours, and there should be audiometrically documented sensorineural hearing loss along with fluctuating oral symptoms such as hearing, tinnitus, or fullness in the affected ear, with other causes being excluded. Now, coming to probable Meniere's disease, the difference is only that there is no documented hearing loss in the probable section. So, if there are only 2 episodes of vertigo lasting for 20 minutes to 24 hours and fluctuating oral symptoms without a documented audiogram, then it is probable Meniere's disease. Now, if you notice closely, the duration has been increased from 20 minutes to 12 hours in the definitive section to 20 minutes to 24 hours in the probable Meniere's disease section. So that means if the duration of disease is longer, the chances of it being Meniere's is slightly lessened or it is slightly smaller. Now we'll discuss the investigations part. So first and foremost, what we do is a pure tone audiometry. Now we have briefly touched on this. I'll discuss it in more detail. Now initially there is low frequency sensorineural hearing loss, and this is fluctuating in type. That means that the hearing loss is only during the acute episodes, and in between the episodes the patient is completely fine, that is hearing is completely okay. But however, with due course of disease it becomes permanent. That means that the hearing loss is staying in between the episodes also, and it is not recovering. And also, with due course of time, it becomes a flat audiogram. That is, the higher frequencies are also affected. So, initially, it is a low frequency fluctuating sensorineural hearing loss, and with progress of the disease, it becomes a permanent hearing loss and also it becomes a flat audiogram. Now, another test we can do is CC, that is short increment sensitivity index, and it can help us in differentiating between cochlear and retrocochlear hearing loss. How so? Because it is a test of recruitment which is seen in cochlear lesions. Now, what we do in this test is that we first determine the threshold in the affected ear, and we test the ability of the patient to detect small increments in a suprathreshold tone. That is, we give small 1 dB increments to the patient in a 20 dB suprathreshold tone, and 20 such increments are given. And we test how many of these are detected by the patient. So, for example, if the patient is able to detect 20 out of 20 increments, that means the CC score is 100%. And if the patient is able to detect 15 out of 20, that means the CC score is 75%. And a high CC score, that is 80 to 100%, is suggestive of a cochlear lesion. Now we can also do a couple of special tests, that is ECOG or electrocochleography. In this test, we determine the summating potential and action potential in the ear, and a ratio of them is calculated. If it comes out to be more than 0.35, it is suggestive of Meniere's disease. That is when it is done transtympanically. There are two ways to do it. We can do it extratympanic or transtympanic. Extratympanic when the electrode is placed in the external auditory canal, and transtympanic when we place the electrode through the tympanic membrane onto the promontory, and this is considered more accurate. Now, the sensitivity and specificity are in the range of 70 to 80%. And as this test is an invasive test, it is not done routinely. Another test we can do is a glycerol dehydration test. Now we know that glycerol is a dehydrating agent, so it reduces the endolymphatic pressure, and thus it can cause an improvement in hearing. Now how to do the test? We give the patient 1.5 ml per kg of glycerol orally with equal proportion of water, and we also add some flavoring agent or lemon juice. And pure tone audiometry is done 1 to 2 hours after the administration. If there is improvement of 10 or more decibels in three adjacent frequencies, or there is improvement in speech audiometry of 12% or more, it is considered diagnostic of Meniere's disease, and this is known as Klokhov's criteria. Another test we can do is MRI with contrast, that is to rule out cerebellopontine angle tumors. Now coming to the treatment part, now treatment is aimed at reduction of symptoms as we don't know the exact etiology of the disease, and all the current treatment modalities are aimed at reduction of vertigo as this is the most troublesome symptom to the patient. Firstly, what we can advise the patient are dietary changes. It has been seen that if the patient takes a low salt and a caffeine free diet, there is improvement in the symptoms. Now, the medication part, diuretics, they are considered among the first line therapy. We can give either hydrochlorothiazide, acetazolamide, or spironolactone. They help in reducing the endolymphatic pressure and the volume. Now, clear-cut evidence in support of their use is still lacking. However, generally they are given as first-line therapy. Then we can also give beta-histine to the patient. This beta-histine helps in control of vertigo as it is a weak H1 agonist and strong H3 antagonist. So there are two first-line therapies for Meniere's disease. One is diuretics, the other is beta-histine. The side effect profile of beta-histine is slightly better, and diuretics they cause electrolyte imbalance, so they have to be given with caution. Then the next stage of therapy is transtympanic therapy. We can either give intratympanic steroids or low dose gentamicin to the patient. Now, steroids they are an excellent option when there is intractable vertigo but serviceable hearing is still there. Dexamethasone 8 to 10 milligrams is injected through the tympanic membrane into the middle ear, and several studies they report good control of vertigo, but there is minimal effect on tinnitus and hearing. Now coming to gentamicin is an aminoglycoside which is relatively more vestibulotoxic than cochleotoxic. Thus, it can be used to control vertigo while causing sparing of hearing. Now, current trend is towards single dose intratympanic injection, and further doses are only given if there are still clinical symptoms. And control of vertigo has been found to be superior to that of intratympanic dexamethasone. And reduction of hearing has been found to be negligible. And Whatever negligible it is there, it is attributed mainly to the natural history of the disease and rather than due to gentamicin. Now coming to the surgical treatment. Now the first procedure described is endolymphatic sac surgery. Now a variety of endolymphatic sac surgeries have been described, ranging from simple decompression of the sac to placement of shunts in the endolymphatic sac also have been described. Now, simple decompression means that we just remove the posterior fossa dura over the endolymphatic sac area. Now, we can identify the endolymphatic sac area with the help of Donaldson's line. Now, we'll see with the help of this diagram that what is Donaldson's line. So, this is a picture of right mastoid with cortical mastoidectomy already being done. So, this is the anterior part, superior, inferior, and posterior. Now this is the lateral semicircular canal, this being the posterior semicircular canal, and this being the short process of incus. Now what we do is we draw an imaginary line along the axis of lateral semicircular canal, which almost bisects the posterior semicircular canal. The endolymphatic sac lies just below this line. And what we do in the surgery is we remove the posterior fossa dura over this sac area. So this was the Donaldson's line. However, the efficacy of this procedure is still controversial. Next, what we can do is vestibular nerve section, and we can approach the vestibular nerve either by a retrosigmoid approach or middle cranial fossa approach. Complete vertigo control in the range of 90 to 95% is achievable through this procedure. The drawback is that it is an invasive procedure and it is technically challenging. Now, the most destructive procedure we can do is a labyrinthectomy. An ideal candidate would be the one who has no functional hearing and has failed all the conservative measures. Now, excellent control of vertigo to the tune of 96 to 98% has been reported, and it can be approached by either by transmastoid or a transcanal approach can also be done. Now, I'll quickly recap the Meniere's disease for you. So Meniere's disease is an idiopathic inner ear disease characterized by spontaneous vertigo, fluctuating sensorineural hearing loss, tinnitus, and oral fullness. And the pathophysiology mainly attributed to endolymphatic hydrops, where there is increased pressure in the endolymphatic chamber. Now, the vertigo is a classically spontaneous rotational vertigo lasting for at least 20 minutes, accompanied by nausea and vomiting without there being any loss of consciousness. Hearing loss is initially fluctuating in type, which later becomes permanent, and initially low frequency sensorineural hearing loss is there, which becomes a flat audiogram with time. Now, the diagnostic criteria, we have two classes, that is definitive Meniere's and probable Meniere's. In definitive Meniere's, there should be at least two definitive episodes of vertigo, audiometrically documented hearing loss, along with fluctuating oral symptoms. In the probable section, the only omission is that the hearing loss is not documented. Investigations, what we can do are pure tone audiometry, where the ability of the patient to detect small increments in a suprathreshold tone are seen. A high score of 80 to 100% is suggestive of cochlear lesion. Special tests we can do are electrocochleography, glycerol dehydration test. Coming to the treatment part, dietary changes we can advise to the patient are a low salt diet and a caffeine free diet. Medications, first line medications are diuretics and beta-histine. Then coming to transtympanic therapies, we can either give steroids or low dose gentamicin, with the control of vertigo being better with gentamicin. Coming to the surgeries, the simplest procedure described is endolymphatic sac surgery. Then comes the vestibular nerve section, where the vestibular nerve is sectioned. Vertigo control rates in the range of 90 to 95% are described. Then the most destructive procedure being labyrinthectomy, where 96 to 98% control is achieved, but it should be done only in patients who have no functional hearing, where all the conservative measures have failed. So this was all about Meniere's disease. I have tried to make it very concise and still very informative. If this was helpful to you, you can support the channel by liking the video and subscribing to my channel. And if you still have any queries, please write to me in the comment section. Thank you.